junior doctor, and I'm here to help you revise paediatric epilepsy. It's a big topic that has loads of details, but let's try and go through the basic topics in this revision video today. So the plan for today's revision is we're going to discuss a case that represents a typical epilepsy scenario in children. We're going to talk through investigations, the classification of epilepsy and how this translates in different presentations, the management and the complications, and we're going to dedicate the last part of this video discussing status epilepticus as a medical emergency and the appropriate treatment. So starting with our case, a 14-year-old girl, Amy, is brought to A&E by ambulance from a school. Her teacher said that she first saw Amy losing consciousness and falling to the ground. A few seconds later, her full body started shaking and she let some urine pass. So, on examination, Amy is no longer shaking and is in A&E feeling drowsy. Her full neurological exam is otherwise unremarkable. Observations are normal, and her ECG shows no abnormalities. This is a normal ECG. So let's break down the case a little. It's here to the left. So what is this type of seizure? So this is a typical presentation of a generalized tonic-clonic seizure, which is a generalized seizure affecting the whole of the brain that presents with stiffness first, and that's the tonic part of the seizure, and then with a clonic phase as the part that involves the shaking and the jerky movements. So let's break down the features that are present in this scenario. First of all, Amy's losing consciousness. Loss of consciousness is importantly the first part of a generalized tonic-clonic seizure, as these patients lose consciousness first. If they're awake, if they're walking or standing, they're going to fall to the ground, and then they're going to go into the stiff phase where all the muscles become very rigid, and then they're going to go into this rhythmic jerky movements, which is the clonic phase. Commonly when parents or carers describe these seizures, they miss out describing the stiffness phase because it's not really obvious, although some others will do. The next part is incontinence, where during the seizure, Amy lets some urine pass. Fecal urinary incontinence or tongue biting are features that can happen during a generalized tonic-clonic seizure and are really important questions to ask when you have a suspected case of a seizure like this. So never miss out asking about these because they won't be present for other causes of loss of consciousness. When Amy is in the A&E, she's still feeling drowsy. This represents a prolonged phase of recovery, and that is what we call a post-ictal phase. In epilepsy, patients can remain drowsy for quite a bit of time, and that is another hint that helps us work out the diagnosis of a generalized tonic-clonic seizure. So what happens next? Let's talk about investigations. So we need to rule out non-epileptic causes of seizures, and this is particularly important because non-epileptic causes are mostly reversible and very easy to treat and can restore normal brain activity. So in an acute presentation of seizures, the test that we need to do is first do observations. We need to pay particular attention to the saturation levels because patients who are shaking or have lost consciousness are at an increased risk of not having a normal breathing pattern and not being able to maintain their oxygen levels, leading to hypoxia. Secondly, particularly in children, we should never forget to take note of the temperature. This is because there is always the consideration of a febrile seizure and not epilepsy, especially in children under the age of 7. Febrile seizures happen in young children as a reaction of the body to the very high temperature when they are unwell, and this is an important differential. It's important to reassure parents and tell them that this is not epilepsy, and to tell them that it is likely that this will not happen again. 1 in 3 children might get it again if they become very unwell again and get a high temperature. The risk of epilepsy with febrile seizures is only marginally increased but still remains less than 1%. So moving on, other investigations, we need to check glucose either through a cup glucose or a VBG or an ABG, because hypoglycemia is an important, never to miss, easily treated cause of seizures. An FBC to see how the patient is doing in general, see the possibility of an infection, potentially one in the nervous system like meningitis that could be causing seizures, and then check electrolytes like calcium, magnesium and sodium that when outside the normal range can cause seizures as well. We should never forget to do an ECG as cardiac problems are associated with seizures, and it's important to rule out cardiac problems that can also predispose to sudden cardiac death. Follow-up tests. Remember that epilepsy is a clinical diagnosis and no follow-up test can be diagnostic for the condition, but it's important to first do an imaging study like MRI, which is preferred in children because of the lack of radioactivity compared to a CT scan. So an MRI can be used to rule out specific causes of epilepsy like a space-occupying lesion or a structural abnormality in a specific part of the brain causing local abnormal activity. And we can also do an EEG, a specialist is usually doing this. Take note that EEG has a very low sensitivity, so it's not particularly useful and definitely not used to rule out epilepsy. And remember that it's a clinical diagnosis, as we said.